if stuff's not sterile at the beginning of the case, orthopedic trays get brought in from outside sources and they didn't get reprocessed properly or whatever, or they're waiting for something to get delivered, that just becomes an inconvenience. It's a frustration. Any time that the operating room is not being used, it's essentially costing more money, because things are being delayed. Surgeons get upset. It just makes for a rough experience for everybody.
Rising above the buzz of ultrasonic cleaners and the clanking of stainless steel are the ideas and voices that are changing an industry. You're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are improving our sterile processing world. Each week, we speak with frontline technicians, CEOs, engineers, and entrepreneurs with a common goal: to help you fight dirty, every instrument, every time. Whether you're tuning in for education or inspiration, we're glad you did. Now turn on those washers and turn up the volume. It's time to go beyond clean.
Hey there, Sterile Processing Universe. My name's Hank Balch, and with me in studio today is...
I'm Bobby Parker.
And you are listening to season 27 of Beyond Clean. Hard to believe that we are at that number. And this season is themed Planet Surgery, where we're taking a look at surgery and what's happening in that room. And we're tying it all back to the instrumentation side of this, trying to look through new eyes, if you will, at the different processes and people that our instruments go through and impact in the OR room. So on this episode today, we're going to be talking to O.J. Skiles, a CRNA. So we're going to be talking about anesthesia, instrumentation, their opinions on delays in the cases. Bobby, this is going to be a really interesting one.
Yeah, for sure. And got to talk to OJ a little bit. Sounds like you guys have a little bit of a connection for one another. So thanks for pulling some strings and getting OJ on the show. It'll be a good conversation. I've known a couple of folks who started in sterile processing, fell in love with surgery, and heard some good things, saw some good things about anesthesia, and went that route with their career. And so I'm excited to hear from OJ about his perspective on CRNAs as a whole. Is it a good gig or not? Does CRNA stand for coffee required, never awake, just like a drudging schedule, or is it a good gig? So it'll be fun to jump into it.
Yeah, there's a lot of puns when it comes to anesthesia, and we're going to have a couple. I just want to make people prepared for that. All right, y'all ready to get some sweet dreams? I thought so. Stay tuned with us, and we'll be right back with O.J. Skiles.
From the studios of Healthcare HQ, you're listening to Beyond Clean, the global voice of sterile processing.
All right, clean freaks, welcome back to the studio. We're going to put you to sleep on this one, but in a good way. I'm hoping you'll learn some things while you go to sleep here. We got O.J. Skiles in studio with us today, out in PA. He's a CRNA, and he also happens to be... Well, our wives are cousins. I practiced this before it went live, OJ, and I still stumbled on it. Our wives are cousins. We are related. And we had, dinners and stuff together throughout the year, OJ. And I finally found a good excuse to get you on the podcast with us because I knew that you did this. And I was like, oh, man, how do we get him? How do we get him on? And then this season was the perfect season. So thanks for joining us today.
Yeah, you're welcome. It's great to be here. And it's nice to see you again. And looking forward to this conversation.
Yeah. So I was telling you before we started, the primary audience of this show is going to be sterile processing folks, although we do have folks from all around the surgical services workflow. Can this CRNA credential is one that's very common in the OR, obviously, so you're going to see it around all the time. But folks may not exactly know what it is. Before we get to that, give a little bit more background. So I'll give you your name and your location, but how'd you get to where you are today?
So I've been doing this for around 13 years. And when I was in college, I didn't really know what I wanted to do. And my wife, another cousin, is a general surgeon. And so I was talking to him just about career path and that sort of thing on an Easter break one year. He said, "Hey, have you ever thought about nurse anesthesia?" I was like, "No, I don't know you know what that is." So we hopped online and kind of looked at what was required and kind of the duties and such. And he kind of said, if I could do it all over again, that's what I would do. The schedule's great. Like, I don't have to put in office hours. If I choose to do call, which, 24-hour shifts, I can, but, the malpractice insurance is less. And it's just overall a really great lifestyle and benefit. So that's what I got into. And you have to have a minimum of a year of critical care nursing experience after you get a bachelor's degree. So I did a little bit of telemetry nursing right out of nursing school. And then I went and got some critical care experience in Philadelphia, and then went back to anesthesia school at Villanova, graduated in 2011 with a master's degree in nurse anesthesia. So,
okay. So you have to get your BSN as a step on that journey, basically.
Right.
Okay. Good.
So, and then, like I said, a year of critical care experience. So by the time you actually start school, schools will be accepting classes 2 to 3 years in advance. So when you're in school, you have to be in school pretty much full time. You can't work. So you have to get financial aid to cover your mortgage payments or your bills or whatever. But
is that like a wife? Is that what you mean? Like you got financial aid,
or a sugar mama?
You got to get married. Yeah. Okay. So what about, you said telemetry, and I'm going to learn a lot of things on this episode, and I'm going to start with that one. What is that? Because I've heard that word before, and I don't have any idea what they do.
Yeah. The telemetry unit is a unit where people come in with some kind of a heart problem, or they may not be admitted to the hospital for a heart problem, but they do have existing heart problems that need to be monitored. So it's a heart monitoring unit where every patient has, either a remote box that they carry around in their hospital gown that's being monitored in a central location, where you have monitor techs, two or three, and they're watching all the monitors, for every patient all the time.
Okay, great. So what about the role itself? Once you get into a surgery, or, perhaps your responsibilities begin even before the surgery, I'm assuming. But kind of talk us through what a CRNA does in surgery, and then I'll have a follow-up after that.
Okay. So it starts, as I'm setting up my room, I've got to check the machine out. I draw up the medications based more or less upon the patient's history. So I'm looking through their chart, figuring out what kind of chronic diseases they have, or, the kind of surgery we're going to be doing. The anesthetic is tailored towards the patient specific as well as the intended operation. Different operations have different nuances. Like if you're doing a lung surgery, you would need to ventilate only one lung while they operate on the other lung. So there's certain equipment that has to be utilized for that to create that space, so to speak. So you're reviewing the chart, you're drawing up the medications, getting the necessary equipment. You go to meet the patient, interview them, follow-up questions on different things that you noticed in their history, and you kind of explain to them what's going to happen. I find that the more informed a patient can be, the better outcome they have, or perceived outcome, if you will. The experience for the patient is a lot better when they know what to expect. And so, that's kind of the beginning of it. And then we take them back to the operating room, and then the whole operation happens. So okay. Did that answer your question?
It does. Yeah. We're going to pick up on the operation piece here later. What is the difference then from what you do than what an anesthesiologist does? Is it the same thing? Is it just different titles? Kind of talk us through those.
So what people don't realize is that nurses were the first ones to be giving anesthesia. So nurse anesthetists have been around for over 150 years. The technical CRNA credential came around in the 1950s, but nurses were the first ones to provide anesthesia like during the Civil War. But in terms of like day-to-day operations, anesthesiologists and nurse anesthetists work in conjunction with one another, I would say the majority of the time. In the armed forces, CRNAs are the only providers of anesthesia, like on the front lines. I think that's the case in all the branches.
Is there a reason for that? I mean, like an anesthesiologist just not brave enough to go to the front? No, I'm just kidding. But yeah, like what's the reasoning behind that if they're basically doing the same thing?
Since I've never been in the armed forces, I don't know exactly. Okay. But my guess would be is because doctors are higher rank. And so higher ranked officers aren't put in those kind of operational type things. That's just my speculation, I guess.
Is there a licensing balance then? I know, like, depending on maybe what state you are, does that impact who it is or like what credentials or licensing you need?
Yeah, a lot of it comes down to, whether a state has opted out of a Medicare requirement for reimbursement. And so it comes down to like a billing situation. But largely, anesthesiologists and nurse anesthetists, they're the same. They do the same job via two different career paths. Anesthesiologists have a medical degree, or they're either MDs or DOs, and nurse anesthetists now are doctoral prepared, but the practice of anesthesia is the same. If the doc is in there giving anesthesia or a nurse is giving anesthesia, they're giving the same type of drugs, going through the same motions, so to speak. It's just, did you want to go through a medical school career path or a nursing school career path to do it?
They don't have better drugs. Okay.
No.
That's good to know.
OJ, you gave us a great introduction to kind of the workflow and what that looks like as you interview the patient and then bring them back to surgery. In the OR suite, obviously, there's a lot of surgical instruments being used, and the majority of our listeners are coming from a sterile processing background. Of all those instruments that are being used in the operating room, are there many, if any, that are used by the anesthesia team during the procedure?
Well, that's a good question. As you guys probably know, a lot of things are going to single-use items. When I first came out of school, it was rare you would see single-use laryngoscopes, but now I haven't seen a reusable one in a long time. So the blades and the handles would get reprocessed. It started out that the blades would go get reprocessed, but the handles would just get wiped down, before the next case. But then it was both things got reprocessed, and now everything's single use that I've seen. Maybe some of the more rural settings, you might get reusable, stuff. As an anesthesia provider, we're the masters of the airway. So that's kind of our focus, to make sure that the patient's airway is secured before surgery. So that means some kind of airway protection device like an endotracheal tube or a laryngeal mask airway. There is a reusable LMA, and it's called an intubating LMA. Those things get reprocessed, but those aren't really used often. Those are like rescue devices. If your first line of airway securement, if you will, fails, you can put an intubating LMA in, and that'll help you ventilate while you get the necessary stuff to intubate through. If you think about surgery in the mouth or the teeth or the tongue or something like that, throat surgery, sometimes we need to secure the airway through the nose because they're working in the mouth. And so we'll use like a McGill forceps to help direct the endotracheal tube into the larynx in conjunction with a laryngoscope blade. If you're familiar with the glide scope, they make reusable stylets that just make the endotracheal tube more rigid so you can direct it where it needs to go. There's some emergency airway stuff, fiber optic bronchoscopes. All these are airway things. If we're doing cardiac surgery, we need to do transesophageal echocardiography, where we're looking at the heart through the esophagus with the ultrasound probe to give us ultrasound images of the heart during the surgery to make sure that the heart function is what it should be. So the TE probes get reprocessed as well.
Right. So it sounds like a little bit more than maybe we would expect. In all the times that I've been in an OR, either supporting them through sterile processing or coming on site as a consultant, which admittedly isn't a whole lot of time in the OR, it seems like when I'm watching a case, the anesthesiologist or the nurse anesthetist seems to be the one guy in the room who's most willing to talk to me about what's going on in the procedure. And I don't know if that has anything to do with maybe not having as much direct relationship with sterile processing. They don't have as much skin in the game, maybe, or what is that? Why is the anesthesia provider the friendliest guy in the room? I guess that's what I'm asking.
That's a good observation. That's funny you say that. I don't know. I love what I do, and I work with a lot of people who love what they do. And once all the beginning of the surgery is over, we're watching the vital signs and we're kind of like cruising along. So we are active, but it's more of a sitting back active. And so we can talk as we're watching the vital signs beep across the monitor. And we're used to trying to help people be at ease and try to get them comfortable before surgery. And I think that translates to students in the room or consultants or whoever. Just we love to talk about, the operating room environment.
That makes a lot of sense. It reminds me of the illustration of a hot air balloon driver. Seems like a pretty relaxing, easy job when the weather's great. But when the storm comes, I'm sure it gets incredibly stressful.
Yeah, absolutely.
Yeah.
So, OJ, your list of instruments that you mentioned there, like from the McGills to the laryngoscope blades to the TE probe, I'm listening to that list, and you may not know this on your side of the table, but that is like some of the most complicated, frustrating instruments. Like the McGill's a little bit different, but just the workflows of like this part gets wiped down, this one gets reprocessed, you got to replace the batteries, got to check the batteries, got to package it in a way that it can still be checked, that way it's ready. And then like with the T probes, like where are they being reprocessed? Do you have the right equipment? Are you transporting appropriately? I mean, those are like some challenging instrumentation. But to Bobby's point, obviously, depending on what's happening in the procedure with the hot air balloon metaphor there, instrument issues, even unrelated to the instruments that you're using, could have an impact on the direction that the case takes. What's your experience been from the anesthesia side of if there's a case delay because of instrumentation? And this could be broken instruments. This could be dirty instruments. These could be instruments that they can't find, maybe instruments that were dropped. When those things happen, does everybody look over to you, or like, do you call out what's going to happen next? Or like, yeah, talk us through that.
In my experience, I feel like I don't see too many anesthesia related instrument delays. Our stuff is not used as frequently as the surgical instruments. So the stuff that I listed oftentimes is more, like emergency airway stuff where they're rarely pulling it out of the cart. So the cart's normally set and locked and it gets checked on a regular basis. But from a surgical instrument issue, if stuff's not sterile at the beginning of the case, orthopedic trays get brought in from outside sources and they didn't get reprocessed properly or whatever, or they're waiting for something to get delivered, that just becomes an inconvenience. It's a frustration. Any time that the operating room is not being used, it's essentially costing more money, because things are being delayed. Surgeons get upset. It just makes for a rough experience for everybody. The patient's not happy. They haven't eaten for 12 plus hours. And so you have those kind of inconveniences. They're not life or death situations yet. But once you get into the room and your patient's under anesthesia and they're bringing in a tray that they didn't check it properly before and they find that it's not sterile. Well, now you've got a patient under anesthesia with all the risks that are associated with that, and then causing this delay. And you've got maybe an open abdomen or something that you're waiting for, some kind of Omni retractor or whatever. And the one's being used down the hall. Now what do you do? And so
what do you do? Yeah. Talk us through that, because that's exactly what I'm wanting to get at. Is on the SPD side, we get a phone call and we're like, hey, we need another Omni retractor to room 6 because this one didn't have an indicator. And, and there may be some other information shared too, hurry, stat, we need it, patients on the table. But we don't really get to see what you see in the room when that happens. So, like, what are the conversations? Like, what do you need to do as the anesthesia provider in that scenario? And then also, we know that there's a risk to longer anesthesia, but I'm not exactly sure what those risks are. Can you speak to those as well?
Yeah. The body receives the anesthesia, and the effect of the anesthesia is cumulative over a lifetime. So if you were a kid and you had a lot of problems and you spent a lot of time in surgery, your overall risks of anesthesia complications in terms of like mental delays or that sort of thing is kind of cumulative based on the amount of hours you're under anesthesia. So let's say you have a 70-year-old or 80-year-old or 90-year-old, and they're under, they had a bowel obstruction and now they're getting this, XLAP procedure. Well, the longer they're under anesthesia, the more risk that they'll have of having some what's called postoperative cognitive dysfunction. And so that's that confusion, that disorientation when they're coming out of anesthesia. So the less time we can expose them to the anesthetic, the better. So if the instruments can get there sooner, it just keeps things going on. And let's say we haven't even made incision yet. The patient's just sitting there and we're waiting for an instrument, but they're under anesthesia. We're not going to wake them back up, if we know it's all going to be 20 minutes. But that lack of surgical stimulation, you're giving medications to support their blood pressure, because all anesthetics are cardiac depressants. They drop your blood pressure, they drop your heart rate. And so, there's risks obviously with that. So you're augmenting them with medications to keep their blood pressure up while we're sitting there waiting for stuff to get processed.
As we're thinking about the OR workflow and what's going on in the room and, how do we avoid those kinds of delays? I'm curious, what are some of the factors that you think have the most impact on being able to get through the case efficiently versus maybe a case taking longer than it should have? I mean, that certainly can include delays related to surgical instruments, but I'm sure there's a whole host of other things that could go on to delay a case.
Yeah. When you think about what it takes to get a patient into the operating room, there's, sometimes months that precede that of testing or preparations. So, OR efficiency is just one small piece of the puzzle, because you've got admissions, you've got pre-op, all those things. Room turnover time is big, just making sure you have the right personnel once the case is over to come in, clean up, and get set up for the next one. And I know, nurses and techs will pull supplies for the next day and put them on carts, get them all ready to go. And so making sure that the preference cards are up to date so that the surgeon has what he needs and he's not sitting there going, I always use this. Why don't you have it for my procedure? And so, the circulating nurses running and grabbing different supplies. I think those things are what contribute mostly to good, efficient, operating room environments. But.
Yeah. So there's a lot of moving pieces then that go into getting a surgery scheduled. Hank and I both came from working in sterile processing as SPD techs and took our rotations working on the weekends on Saturdays. And you knew it was going to be a rough Saturday when you looked at the surgical schedule. And even though there weren't any cases on, you saw that one doctor that it seemed like they were out on the street asking people to come into the ER to get surgery. Like how real is that perception? Is there really that kind of add-on culture where some docs are just really aggressive about getting those weekend cases added on, or is that just a figment of the SPD imagination?
No, I think there's certainly some like that. And you talked about OR efficiency. I think having a good surgeon is probably one of the top things of keeping things moving along well. If somebody described a surgeon, oh, he's really good, but he's really slow. I don't know. Those seem to be oxymorons to me. You should be able to be good at what you do and yet move along and not, slow things down. But certainly there are those surgeons that always seem to find, plenty of patients that still have their appendix or a gallbladder that need to come out over a weekend.
Yeah. All right. So OJ, as we move here slowly to a wrap up, got some maybe smaller questions here to throw in at the end. Through the years, just kind of being around healthcare and consuming a lot of content around healthcare, I've come across a couple of times this thing about anesthesia in redheads. Is that true? Is that a myth? Like, they just tell you can't put them to sleep. Like, it's hard. Like, you need more anesthesia and everything else. Like, is that true? If so, why? Or if not, like, why is that so pervasive of a myth?
Oh, that's funny. Yeah, that's the thing.
Okay.
And it's been a while since I reviewed the science on that, but yeah, it has something to do with liver enzymes, I think, and being able to process medications quicker and break them down easier.
And so, like, if you see a redhead in pre-op, you're like, gotta up that dose.
Yeah, probably.
Wow.
We largely say we titrate our drugs to the intended effect. So it's not like everybody gets 200 of propofol and then we just call it a day. It's, we give what we think is the appropriate dose. If that doesn't work, we give a little bit more and until we get what we want. It's anesthesia always wins. You can't fight it. Doesn't matter how much you require. We'll give you enough to get you through.
All right. You mentioned at the beginning too the type of potentially, definitely the amount of anesthesia depends on the procedure as well that's happening. I think we've probably all seen videos or photographs of those brain procedures where the patient is like playing a violin or a guitar. What's happening there anesthesia wise that they can be doing what they're doing and this guy's just, picking away?
I've never been involved in a procedure like that.
Okay.
Those are pretty specialized brain things that, that's pretty much Hollywood.
I mean, like they're under anesthesia though, right?
They do have functional things like carpal tunnels or trigger finger releases. They'll numb it up with some local anesthesia. And then at some point, they're going to want the patient to move their hand to make sure that the trigger has been released. So, you get them asleep for the numbing part. And so once the finger's numb, you can let them wake up so that they can interact. They may not remember that because of drugs that we've given at the beginning will cause some amnesia. There is some of that going on sometimes.
I don't think we've alluded to this yet. But we know there's anesthesiologists. We know there's CRNAs. We also, a lot of facilities have what's called anesthesia techs. What do they do that's different from everything else we've been talking about here?
So anesthesia techs usually keep our anesthesia supplies in stock. They turn over the machine, wipe things down in between cases. If you're in the middle of a procedure, you're like, hey, I need an IV pump. You call your tech and they'll bring it to you. They assist what we do. They may set up a blood warming setup for us or an arterial line or, just help prepare anesthesia specific supplies for whatever we need.
Okay. Is that a role? If we have folks who are tuning in and by the end of this, they're like, that's what I want to do. And we got a lot of folks who go into sterile processing who see it as an entryway into healthcare in general, some exposure to other places to go. And so they're thinking, what's next? And if this is one of the topics, they're like, I kind of want to evaluate that, or I want to start preparing myself. Is there a particular role like anesthesia tech? Like, is that a good pathway in? Like, I know you got to go to nursing school either way, right? So like that's got to happen. But what else would give you the kind of exposure or, training or anything to potentially get you best prepared?
Yeah, I think the surgical tech route, if you like the hands-on in surgery, being scrubbed in, handing off instruments, and, you can go on to become a first assist or something like that. Those are all good ways. Anesthesia techs, they're really helpful, get you in the operating room environment, assisting with the anesthesia. Various facilities allow techs to do different things. And I'm not sure if there's a certification for anesthesia tech. I knew of one guy who was a, quote unquote certified anesthesia tech. He was kind of the exception to the rule. I don't know too many who are actually certified, but they seem to enjoy what they do, and it gets them in and around the environment and can decide and kind of see what roles everybody plays and kind of figure out what road they want to go down.
Well, OJ, before we close here, Is there anything else you would like the sterile processing community or maybe even other peers in the OR, like what would you like them to know about your role, your job, maybe like misconception, anything that you want to close with here?
Well, the operating room, I think, I don't know. I've never been a processing tech or whatever, but, from the interactions I have, they're always, I'm dropping off supplies and they're in there and they're gowned up and they're scrubbing stuff. And it just seems like maybe they don't really enjoy their job as much, but everybody plays a part in getting somebody through a really troubling time in their life. Nobody likes to have surgery, whether it's cancer or, having kidney stones, these are major inconveniences in people's lives. But to get them through without complications is a really, that's what all of our goal is. And we all play a part. I may have the anesthesia part of it, but if they're not getting clean instruments, they're going to get wound infections, and that's going to lead to a whole host of things, none of least of which is death from sepsis or something. So while it may be monotonous, while it may be a thankless job sometimes, it's such a huge and important part of a surgical experience, is to make sure that the instruments are clean and ready to be used when needed. So don't be discouraged while it's such a tough job and hard. And the one I was listening to the other day from you guys are short staffed. It always seems like they're short, and I appreciate what you do. And so I keep up the good work. And even though you don't get thanked every day, we do appreciate it. And so that's how
Awesome.
I would close it.
Yeah. All right, OJ, really appreciate your time, your insight here. I learned a lot, and I know our audience will as well. If folks have additional questions just about how to get into this industry and whatnot, I'll get your email contact maybe or something like that, and we can connect them either through LinkedIn or what have you if you're on there. And yeah, thank you for what you do. Obviously, you're absolutely right. When we're in those scenarios, we want to be asleep and we want to wake up again. And we didn't talk too much about that side of the anesthesia side, but that's just as important.
Absolutely.
So yeah, thank you
we
for what
sell
you
round
do.
trip tickets in anesthesia, not one ways.
Amen. All right. Thanks, brother. Have a good day.
All right. Thanks.
All right, that was OJ Skiles, CRNA, out in PA, Pennsylvania, my neck of the woods. Oh, well, I guess it used to be my neck of the woods, Bobby. Not so much anymore. Back home in the heartland of America, Texas. But anyways, this outro is not about me. It's about this fantastic interview that we just had with OJ. Dude, I learned a ton. And I'm glad I was able to slide that redhead question in there, because that's always challenged me. Yeah, you hadn't heard that.
Believe it or not, I haven't heard that one.
Okay.
And, but yeah, it was a good interview. OJ fits the mold for CRNAs that I've talked to. I only personally know 3 of them, but I've talked to, I don't know, we'll say 20, which isn't a whole lot, but the record remains unbroken. They all seem to be really nice guys. And OJ was a great guy. Even gave us a little proud dad pat on the back. Keep going, son. We're proud of you there at the end. It felt good. So yeah, it was a good interview. I also learned quite a bit. I appreciate your, we'll call it humility in running these interviews and asking the questions like, what the heck's telemetry? So nice job.
I mean, yeah, if you think it's a put on, it ain't, because I really want to know the answer to these questions too. All right. What stuck out to me in this interview when we were talking about the instrumentation involved on the anesthesia side, and I called it out even in the interview, those blades, massive headache, massive joint commission risk, the same thing with the T-probes, same thing with the McGill forceps, those are often or can be the Pakistan instruments that make their way back in to the trays, and it just goes crazy. And then how do we package them? And then we find them open in a pill pack sometimes. And even the anesthesia carts, we just referenced that real quick, but that process of tracking and locking and refilling, that is a challenge. So this interview, even though the focus is on what's happening in the room, man, there's a lot of implications out of this for SPD to dig into more.
Yeah, we didn't even talk about the ventilators, but disinfecting the pieces to those and disassembling them and the bellows and all the complexity that goes into that. I don't think that's any SPD's favorite thing to get in the department. So yeah, definitely a lot of complexity to the anesthesia stuff.
All right. Well, depending on the feedback that we get on this show, if the audience, if y'all want to hear more about these things and carve it up, I don't know, maybe we do a little webinar series on these various topics that touch the anesthesia side of it, different instruments, different processes that we call out. Or heck, if there's enough feedback, maybe we'll do a whole season one of these days and just go through one by one all of the various challenges that we outlined today. But we want to hear from you either way. If you loved it, if you hated it, you're not going to hate it. But if you loved it or if you want to do something more on these topics, please reach out to us at info@beyondclean.net. And anywhere that you happen to see this podcast episode posted, we want to hear you in the comments section, LinkedIn, Facebook, Twitter, X, and YouTube, as well as obviously you can listen on the Beyond Clean mobile app that's available on Apple and Android. But we got a fantastic rest of this season, 27 Planet Surgery queued up for you. We got some great guests. We're going to continue these different perspectives on what happens in the room and why that matters for SPD. But until then, like we tell you each and every week here at Beyond Clean, keep fighting dirty.
Thank you for listening to this week's episode of Beyond Clean. As a reminder, you can help support us by subscribing to Beyond Clean on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for Beyond Clean in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@beyondclean.net. We look forward to hearing from you.